going?
Okay, good. Just want to make sure that everything is good.
Now we'll start shortly and just see a few more people to join. We'll start shortly.
Okay, that works.
Chanel, you let me know.
Yeah, we can start whenever you're ready, Prof. When you feel it's been enough time. Yeah.
Okay. Good afternoon, colleagues. I think let's start our webinar for today. This is a series of global health webinars that the Department of Global Health conducts, and today we're privileged to have Dr. Moussa Sarr from Dakar, Senegal, who is going to talk to us on the implementation of the Advanced HIV Disease Package of Care using a public health approach. And these are lessons from Senegal. And so I'll just briefly introduce Dr. Sarr, who is serving in Dakar, Senegal as the principal investigator and the head of the cooperation group at the Institute for Health Research, Epidemiological Surveillance and Training, in brief, IRISEF. It's also written in French, which I struggle to pronounce in French. It's nice that Dr. Sarr was kind enough to write it in English. Yeah, so just a brief bio as a way of introducing our speaker for the seminar today. Dr. Sarr is a physician and an epidemiologist with over 25 years of experience in public health research and program implementation. He has led and supported numerous projects across Africa, Asia, and North America, particularly in the areas of HIV/AIDS, TB, vaccines, and maternal and child health. He currently serves as the head, like I said before, and the principal investigator for several initiatives at this IRISEF. Also, he's done work including the pilot implementation of the WHO package of care for advanced HIV disease in Senegal that was funded by the Centers for Disease Control Foundation in the US. Before then, he spent approximately 20 years working as senior study director and principal investigator for the WestArt in Maryland, America, but he decided to come back home to Senegal to lead multiple initiatives in the control of HIV and AIDS. During this time, he also served as the PI for several major projects. This included clinical research operations and monitoring center funded by the Division of AIDS at the US National Institute for Health, and strengthening HIV strategic information activities in the Republic of Senegal and PEPFAR program. And so he has vast experience in the field that he's talking about today, having worked abroad in the US for many years and opted to return to Senegal and has done work across the globe, including Africa, Asia, and the US. So we are very privileged to have a colleague who is well experienced with vast knowledge in the subject, and I hope we are going to learn a lot from him in this talk today. Welcome, Dr. Sarr, and thanks very much for the opportunity to share your expertise and your knowledge in this field. And you can take the floor. Over to you. Thank you.
All right, thank you very much, Professor Peter, for this invitation. It's a real pleasure to be joining this workshop and presenting this work that we have done in Senegal for the last 4 or 5 years. So we'll be presenting today the implementation of an advanced HIV disease package of care using a public health approach in a public health setting in Senegal.
Dr. Sarr, you muted yourself, so you should unmute.
Oh, sorry. Did you all hear me?
We had the introduction, but then it got muted. Yeah. You're back online.
All right, thank you.
Thank you.
So we'll be discussing the implementation of an advanced HIV disease package of care using a public health approach in Senegal. First of all, I will give you a little overview. I'm sure you all know where Dakar is, but it's one of the westernmost point. It's the westernmost point, in fact, of the African continent. It's a city of 3.5 million inhabitants. And within Dakar, we work at the IRSF, which is the Institute for Research in Health, Epidemiological Surveillance and Training. In French, it's a non-profit organization with a multidisciplinary team of African and Pan-African faculty members, state-of-the-art modern labs, several technical units, and cross-cutting activities from diagnosis, monitoring, capacity building, research, and program implementation. So today we'll be discussing the implementation of the advanced HIV disease package. Why is this important? This is because advanced HIV disease is still a major issue in most of our countries. HIV, a lot of work has been done in HIV. Mortality has decreased. We are living in a world where people can live with the HIV and even in many cases die for other diseases than HIV. But we still have a high mortality rate, mostly among those with advanced HIV disease. And this mortality in that group is not decreasing, and despite a lot of these efforts that have been done in latest years. And some of the causes of those deaths and mortality are related to cryptococcosis or to TB, mostly in our settings. So this is why it is important to implement these packages of care that are recommended by the WHO to hopefully contribute to lowering this mortality that we are seeing in our countries. The package of care has been implemented in several countries in sub-Saharan Africa, but most of those implementation were in Southern and Eastern Africa. We know that in West Africa has some differences, for example, with the presence of HIV-2 and the dual infection HIV-1, HIV-2. So implementing the package of care in our setting will also contribute to scientific knowledge in this area. So this is just to show how that advanced HIV disease is persistent. Approximately 38% of patients who are starting antiretroviral treatment are in advanced HIV disease. So what is advanced HIV disease? It is defined as having a CD4 count less than 200 or having a WHO clinical stage of 3 or 4. This means that having an opportunistic infection or TB infection. Specifically in Senegal, we have found that 35% of our HIV positive patients have advanced HIV disease with a CD4 less than 200 or clinical stage 3 or 4, based on our surveillance data. The other important issue here is that CD4 is still important. Recently, with the viral load testing and the push for viral load testing and achieving undetectable viral loads, in many countries, CD4 testing is no longer supported or even funded. However, CD4 is important as it plays an important role in the staging of not only of newly diagnosed patients, but also in treatment experienced patients. It allows, for example, just simply to know if prophylaxis, for example, for opportunistic infections are needed. It definitely helps for a better care and clinical care of the patients by having a well-tailored treatment and also prophylactic management for these patients. Viral load is pushed for, but is still expensive, and in many countries, mostly in sub-Saharan Africa, sometimes it's even the tests do not come on time. It takes so even for the proper follow-up of patients without viral load and CD4. So in many cases, these are hard tasks for physicians. So just to say that CD4 is still important. Even viral load is also important and key to patient follow-up, but providing also CD4 testing is an additional tool for clinicians for an optimal management of patients. So what is an advanced disease package? We will specifically for the case of Senegal, there's treatment and management that are already done by I would say by the Ministry of Health overall in all clinics. So these include, for example, gene expert testing for TB diagnosis, prophylaxis with cotrimoxazole for those who did it, TB prevention with INH fixed dose, rapid antiretroviral treatment, pretty much treatment for everybody, except those who are newly diagnosed with TB or cryptococcal infection, where there may be need for a deferring treatment before starting antiretroviral treatment. But otherwise, everybody received antiretroviral treatment independently of CD4 and opportunistic infection also. There's also a tailored counseling that is done to ensure optimal adherence. Now, in addition to those interventions, we have added in the study TB LAM testing for TB diagnosis for people with symptoms or sign of TB, cryptococcal antigen screening for everybody. And we have also provided fluconazole for streptococcal to those who have streptococcal antigen positive. We have also made available to the clinicians treatment for cryptococcal meningitis for those who needs it also. So the overall objective here is to assess the feasibility, the acceptability, and the impact of the WHO package of care for people presenting with advanced HIV disease, defined as CD4 less than 200 and a WHO clinical stage of 3 or 4. There's many other specific objectives. For example, just to know what is the burden of disease for cryptococcal antigenemia. This is not known in Senegal at all. There's maybe no study to assess what's the prevalence of cryptococcal antigen positivity among people with advanced HIV disease. Testing also with point of care testing, such as with the TB LAM, is also important. Knowing that many people living with HIV, sometimes even if they have symptoms of TB, sometimes the sputum is not, there's the sputum is not always of a good quality for TB testing. And so TB also can be located in other parts of the body, such as the bones, the kidney, and so on. And those may not be captured by the gene expert from the sputum. So this was a two-phase study. The first phase, we firstly assessed the performance of the VisiTech. The VisiTech is a point of care testing for CD4, just to know if the CD4 count is below or above 200. And we compared that to the FACS count flow cytometry test. During phase 2, we piloted the package of care for those with advanced HIV disease, and followed them up for 12 months to assess outcomes such as death, occurrence of opportunistic infection, and other clinical outcomes. For the first phase, patients had to be 15 years and older and provide consent. That was the same thing for the phase 2. But in addition, we wanted them to not willing to relocate in other areas, so that we can have an optimal follow-up during the 12 months period or at least. And also having an advanced HIV disease was also an inclusion criteria. For the phase 2, for the phase 1, phase 1 was implemented in Dakar. But the phase 2 was implemented in Ziguinchor, Bignona, and Oussouye. These were located in the southern part of Senegal, where we recruited 240 patients, 18 years and older. Initially, we were planning to enroll patients 15 years and older, but with the feedback of the ethics committee, this was changed to 18 years and plus. This is an area that has a high burden of HIV-2 and HIV-1, and we wanted to have that diversity of type and subtype for the implementation. So these were the reasons why we chose to implement in this region. So this is the algorithm for the study. For all patients, we assessed the eligibility for enrollment using the CD4 VisiTech, advanced HIV disease, and we also did the FACS count at the same time. And it's only patients with a CD4 less than 200 and those with opportunistic infection that ended up being enrolled. For the patients with that were enrolled, they received cryptococcal antigen testing. Those who were negative, there was nothing else to do. For those who were positive, we assessed the symptoms for cryptococcal meningitis. For those who were symptomatic, there was a treatment with fluconazole. There's a specific treatment for that. This lumbar puncture, and CSF CrAg testing. And if needed, amphotericin B and fluconazole were given. In fact, we even added up the 5-FC for optimal treatment. Those who are asymptomatic received the prophylactic treatment. We also did TB LAM testing. Those who were positive with symptoms of TB, we also submitted also for gene expert testing and received treatment for TB if those were confirmed that it's a TB, it's a clinical TB. Statistical analysis, overall, we did the proportions, mean, just descriptive statistics, if you can say, to explore study variables and describe the study population. Between group comparisons at baseline using simple chi-square, Fisher's test, or t-tests as appropriate, or ANOVA. Survival analysis was used to estimate the time to death and related predictors, and repeated measures such as GE models were used for outcomes such as opportunistic infection that could occur at 3, 6, 9, or 12 months, and also to investigate related factors. So initially in phase 2, one of the first assessment that we did was to see if the CD, the Visitech point of care was a good test for Senegal, considering that, the type of subtypes of HIV that are present in country prior to implementing it in the sites. We ended up having a great sensitivity at 92, close to 93%, and also specificity also great at 91%. So patient characteristics, most of our population was approximately 48 years old. This is the mean. Mostly female at 69%. Mostly Senegalese, of course. Married, is HIV-1, mostly divorce. I'm not sure, we didn't show the married was more. We had 130 married and 31 single. Sorry, we had this in French, so kind of didn't realize that we don't translate these ones. HIV-1, we had 200 HIV-1, HIV-2, 12, dual infection, HIV-1, HIV-2, we had five of them. Another characteristic, most patients were not educated. At least I would not educated may not be the right way to say it, but didn't go to the French school. 104 of them, 61 went to primary school, and 42 went to secondary or university. Sometimes this can be a little bit misleading because we also have education in Arabic, but we tend to mostly assess the education in French. Cryptococcal antigens, the CD4, we found that there was a higher mortality among those with CrAg positive. If we look at deaths, we had 20% mortality for those who had the cryptococcal antigen positive, compared to 2.9% for those who had cryptococcal antigen negative. the seropositivity of cryptococcal antigens was around 4 to 5%. We'll show that in the coming slides. We also assessed non-biomedical factors such as depression. So the Centers for Epidemiological Studies depression scale was translated in French and used. And in this case, we had a overall, I would say it was acceptable the way that it was used in Senegal. If we look at, we had two factor. See. Yeah, the reliability was not shown here, but it's above 7%, above 0.7, which is good. And we had a two-factor loaded, which matched also the original CSD scale that was tested in other countries. You can see here at the bottom of the table, opportunistic infection, yes, no. We had 11% of depression among yes, so yeah, so I think that it's better to look at the odds ratio. We had an odds ratio of 10%, 10.5, sorry. This means that those who were depressed had a likelihood 10 times higher for opportunistic infection compared to those who were not depressed. The confidence interval is quite large because the numbers were small, but it's definitely was a significant association between opportunistic infection and depression in this case. So overall, we enrolled 214 patients in the phase 2. We had a mortality of 39 deaths, which is 18%, very, very, very high. And the cryptococcal antigen prevalence was 4.6. TB, LAM, tuberculosis was 20% positive. We had a mortality of 20% among those with a CrAg positive compared to 2.9 among those who were CrAg negative. The depression measure had a good reliability coefficient at with a Cronbach alpha of 0.79, close to 80. The factor analysis showed that the underlying factors of positivity and negative affect found in the original version was also found in Senegal. And we found a significantly higher likelihood of having an opportunistic infection among those who are depressed. So we are still analyzing the data for the TB LAM. We had some challenges with the longitudinal data that we are still working, so I will not be presenting that. But overall, we had a high mortality rate of 18%, highlighting an ongoing vulnerability among people with advanced HIV disease, despite all the antiretroviral treatment scale-up efforts that are done in country lately. The mortality among cryptococcal antigen patients was significantly high, at 20%, reinforcing the need for systematic CrAg and antigen testing. We have to highlight here that routinely the cryptococcal antigen testing is even not available to clinicians, at least before this study. After this study, we have been able to work with the Ministry of Health, and the package of care recommended by the WHO as presented here will be available for scale-up in country. So additionally, 20% of the patients had a TB LAM positive, underlying also the burden of TB co-infection in this group. Clinical depression was seen as a key contributor to clinical vulnerability among advanced HIV disease patients. Overall, this underscored the importance of integrated approach, not only addressing opportunistic infection, their screening, their management and treatment, but also mental health to successfully overcome mortality and low mortality in this group. So just to say thank you to those who have funded the study, but also the study participants, the Senegalese government that have also worked with us. And as I mentioned earlier, the results of this work were well taken by the Ministry of Health, and we are currently working with them for a scale-up of the package of care in country. Thank you very much. Merci beaucoup.
Merci beaucoup, Doctor. Merci. Thank you very much. The exciting results there that have policy implications in the management of advanced HIV disease. Thank you very much. Very clear, well thought through presentation. Colleagues, time for questions. If you have any question, you can raise your hand and then you can ask the question. Yes, Dr. Juliet Nyasuru, you can go ahead.
Good afternoon. Thanks for such a great presentation. I've got, I don't know whether it's a question, but I would like you to just comment on some statements that I'm going to make. You highlighted in your background that about 40%, 38 is almost 40% of the HIV positives have advanced HIV. And the growing concern is the package of care that came with the 95 strategy, especially in sub-Saharan Africa countries, where we removed CD4 count as the main package of care when we started the test and treat programs. However, right now we are actually acknowledging the fact that there is a lot of advanced HIV, people who come in late, and they still need this. They can only know and make those diagnoses if they have the CD4 count. And lately, there's a lot of pressure to call back the CD4 count as a package of care at the point of initiation of HIV patients. What is the policy there in Senegal, and what would be your comment for our package of care in the sub-Saharan African country region? Thank you. Over.
Thank you, Dr. Juliet. So, Peter, should I respond to each questions at a time, or?
Let's get the second question. Dr. Chishiba, can go ahead.
Thank you very much, Prof. And thank you very much for the nice presentation. Good morning and good afternoon, by the way. My question regards the inclusion criteria for the age From the outset, you planned to also include those that were aged at least 15. But then later on, you mentioned that the ethics committee advised that you stick to those aged above 18. Regarding that, I wanted to find out why they had given that advice. Or was it because of issues to do with assent? And given that you had excluded most of the adolescents, in whom we know that the outcomes are the worst, and they're the ones that will most likely have advanced HIV compared to the other age groups. Do you think having excluded these from the study will make your findings generalizable to this age group of interest? Thank you.
Thank you, Dr. Schubert. So let me try to answer these two questions first. So for the advanced HIV disease patients and the percentage, yes, it is still a sizable number of our patients, mostly those who are newly diagnosed, but we also have patients with challenges with adherence and other related issues who sometimes come back with advanced HIV disease at follow-up. So this is really something important, mostly, as you mentioned, that CD4 has been removed. And as I mentioned earlier, CD4 is still very important for the staging. I mean, you would not know, if patients qualify for certain type of prophylaxis if the CD4 count is not done, and then if you don't know the staging. So overall, in the overall management of the patients, knowing the CD4 count is still very important. So personally, I believe that the idea to remove CD4 and focusing solely on viral load for patient management was I want to avoid saying not a good idea, but we could have done better, basically. Right now, there's a push for using CD4 at point of care, which is less expensive. The results can be obtained pretty much very quickly as the patient is at the clinic. Yeah, so the technical aspect is also simpler. You don't need a high level lab capacity to do that. So even with the qualitative CD4 testing, just having knowing the CD4 is less than 200 or over 200 still can be very helpful to clinicians. So that's right now the way that things are going. For example, in the implementation scale up that is going to be done in Senegal, the Visitech will be purchased by the Global Fund for the Ministry of Health, and will be made available to clinicians for staging. And for now, it's only available during the first encounter of the patients, basically to staging. One of the suggestions we're still making is, can it be available even for follow-up and overall for clinical management? But for now, at least funding is not available to do that. But at least it will be available at the beginning when the patients are initially diagnosed for HIV. I believe that we also those who are lost to follow-up and come back with opportunistic infection, so may also benefit out of it. For those with the opportunistic infection they're already advanced HIV disease, so they may not need to have a CD4 testing. But for those who come back result on OI, but are not doing very well. So hopefully we'll be able to also push to get those also a CD4 testing, even if it's so qualitative. For the inclusion criteria, yes, we initially wanted to have start at 15. And definitely the idea was just that we wanted to have the adolescents. In most cases, we lose that population. They are not included in children. They are not included sometimes in adults. So we really definitely wanted to know what's happening with the adolescents. Personally, I also even have a special interest in adolescent and HIV. But in this case, it was mostly in relationship to the assent issue. We needed to have parents available. So for the overall operations of the study at enrollment, it was going to be a challenge. And I think that they just wanted to have it cleaner, a clean study basically, and not take that many risks in that area. So we didn't want to push too much, because one of some of these is, you have a timeline, you have to start, and sometimes it's just easier to say yes. And then start. But definitely for the not having the data from the adolescents will affect the generalizability, at least to the adolescent population. What we are planning to do is to see, still pull out data from those who are 24 years old and younger. And then just see what we have on those, even though it's not perfect, but at least it may give us an idea about what's going on in that population. So we'll be doing some analysis for patients between 18 and 24 for that. So hope that I answered your questions. Otherwise, please let me know.
Thank you very much, Dr. Sarr. Any other questions from the team? Let me see if there are questions on the chat. Any other questions from no one who has any question? Let me ask, as I wait for people to ask, let me ask one quick question. So advanced HIV disease, if somebody was on antiretroviral treatment, it would most likely be a sign of viral resistance to the either first line or second line, whichever is the recommended treatment or regimen in Senegal. Do we have an idea of the prevalence of HIV viral resistance in this population?
Yes, the numbers are available. I do not have it readily on the top of my head, but definitely if they are followed and they're taking their medication normally, so this may lead to be a sign of I would at least treatment failure, we could say. And then we can then investigate to see what's the reason of the treatment failure, and it can be viral resistance.
Okay.
Yeah.
And then then you had some patients who were positive for both TB and cryptococcal, if not mistaken, if I didn't hear you correct. Were these people on both treatment, fluconazole and anti-TB medications?
Yeah, we did not have people who were at least who needed how would I say, treatment, cryptococcal meningitis, for example. It was mostly prophylactic
Okay.
treatment for cryptococcal. meningitis for cryptococcal. Yes, to prevent for the meningitis. So that's less, I would say, less heavy. It's not as heavy as the treatment for those who are have symptoms of meningitis and also have the CSF positive for cryptococcal antigens. We had one case like that with a full sign and symptoms of cryptococcal meningitis. We tested the CSF, which came out positive, but the treatment, in fact, even ended up losing the patient because I think that there was some challenges with the family who did not agree initially for the treatment. They thought that it was too heavy. So by the time that they discussed and agreed, it got back to us. Pretty much, I would say it was too late.
Okay. So the depression index score, the score or an index that you use to detect depression, was it compared to the non-advanced HIV disease? I was just thinking that this was possibly a unilateral population where everyone else had advanced HIV disease, and so if you use the scale, likely it would be higher because these people have severe disease. If we compared it with the non-advanced, then maybe we would see the predictive performance of this index at detecting depression in this particular population of sick individuals. I was just kind of wondering.
Mm-hmm. Yeah, I mean, I would say my assumption is at least the property of the scale to show that there's good reliability and also that the factor analysis did fit the initial what we expected from this, and overall just to say that this was a good instrument for diagnosis of depression in our setting. I believe that statement is still true or can be still true. Okay. Because technically we would not assume that there's a difference in the understanding, in the language, in the culture of patients with AHD and those without. These are just Senegalese folks who speak the same language, who understand the questions and the questionnaire the same. Now, the prevalence, definitely, I would assume that it may be lower in those without AHD than compared to those with AHD. So, yeah, so because of the level of the disease and several of the disease that they have, this may, I don't know if it's going to be the chicken or the egg, but well, it maybe have some relationship with why they have this high prevalence of depression among those. So we look at what we have in the literature at least, but for sure it's expected to be lower than what we have found in this population. But for the psychometric property of the scale, I can still assume that it would have been the same independently if it was AHD patients or just general people living with HIV.
Okay. As I still look for hands up or indication of questions, let me ask another question. Colleagues, if there are questions, please just indicate so that you can ask the question. So let's look at the cryptococcal antigen test. So every person who had done a positive test were they then given cryptococcal prophylaxis or prophylaxis for meningitis?
Yes. So, yes, everybody with the Yes, though everybody who is positive for cryptococcal antigen, even if they are asymptomatic, will receive prophylactic treatment with fluconazole 800 milligram daily for 8 weeks, followed by fluconazole 200 daily. Yeah, those who are symptomatic and mostly if the CSF we receive fluconazole, but at 1200 milligram daily, and then they'll be referred for lumbar puncture. And then if the CSF is positive after lumbar puncture, then they will receive amphotericin B plus fluconazole and the full treatment for cryptococcal meningitis.
So I was just wondering, in terms of the sensitivity of the cryptococcal antigen test, looking at the prevalence of cryptococcal formants in this population is high. We expect a higher positivity for cryptococcal antigen. But what is the predictive performance of this test at detecting cryptococcal meningitis? Would we assume that every individual that came out positive, assuming they were not given fluconazole, would then end up developing cryptococcal meningitis? Would we make that assumption?
Well, we found a prevalence of around 4.6%, I believe, and that's matches what has been found in many other studies in Africa and even outside. Overall, it has been found to be around 5%. The sensitivity and specificity of the cryptococcal antigen testing, mostly for people with advanced HIV disease, has been shown to be also to be very good to good. And also we also assess the symptoms of meningitis. So it's we don't leave it also just to the screening of the CrAg. But we assume that really here in this population, that's why the test is not usually for all people living with HIV. It's specific to those with advanced HIV disease. And usually the lower the CD4 count, the better is the test. For example, it's even better for those who have a CD4 less than 100 compared to 200. But yeah, so I would say it's for those with advanced HIV disease, you can assume that the test is a good test, to say the least.
Okay. Thank you. Thank you. Points for clarity, questions, colleagues? Anyone who has any points they want to ask or seek clarity from Dr. Sarr on advanced HIV disease? So I don't see any hands. And I have exhausted the points that I wanted clarified also from my side. Okay. And so I assume that we are all happy. Okay, yeah, there's at least a hand, Dr. Chishiba. Go ahead.
Thank you once more, Prof. The findings are very interesting. I may have missed it. Given these findings, what are the planned next steps to ensuring that the policymakers get to have some of these things that have been highlighted in the findings of the study implemented? Thank you.
Yeah, thank you, Dr. Shishiba. Yes, really, this study came out in a way, I would say, out of necessity. Talking to some young physicians, and they mentioning the challenges of diagnosing these opportunistic infections and how sometimes they have patients they suspect have OI such as cryptococcal infection or meningitis, but they may start presumptive treatment, but nothing was available to them for a proper diagnosis, at least something to have a better guidance on this. Really, with partners, we identified that really having this package of care as recommended by the WHO could help improve clinical management of advanced HIV disease in Senegal. So after we conducted this study in close collaboration with the Ministry of Health, the director of the HIV and sexually transmitted disease program was a co-investigator. We also shared all the information with them. So basically, we were with the MOH at the beginning during implementation, and at the end, right now, we are even preparing some manuscripts with them. So as an outcome of all of that, the entire package has been adopted by the country, included into the strategic plan. And right now, we receive support from the Global Fund. So the Visitech, the point of care testing for CD4, the CrAg antigen testing, the TB LAM, all of those will be available. Even the medication, the fluconazole, the Ampho-B, all of those pretty much were not available. I mean, it was a it was really clinicians were completely disarmed, and they really came out to us that way. They had no, for example, amphotericin B or even fluconazole available sometimes in some of these clinics. So we will have all of those will be available now through the Ministry of Health. So I'm not sure if I responded to your questions, but as an outcome of this pilot, there will be a scale up of the package of care overall in country for advanced HIV disease patients.
Thank you very much. That's a good approach. The assumption is fluconazole is still susceptible. I mean, the cryptococcal formans are still highly susceptible to fluconazole in the country.
Yes, that's the assumption, and I believe that because the challenge is fluconazole was not available, so
Okay.
so most likely the pressure of the medicine that will lead eventually to resistance were not that much there.
Okay.
But definitely that's also something to think about. Definitely, Peter, something to so that we can work with our colleague in microbiology and in mycotics to make sure that we do those assessments as we go.
Wonderful. Thank you very much. We would like to say thank you to Dr. Sarr from here, the Department of Global Health and the Faculty of Health Sciences, Medicine and Health Sciences at Stellenbosch University. I'd like to say thank you for your time and the opportunity to share these insights from Senegal. I'm sure they will cut across in other parts of Africa where advanced HIV disease is getting to be a major challenge, despite the increasing rollout of antiretroviral treatment. So thanks once again, and we would like to say thank you, and thanks everybody for the time to join, participate, ask questions, and just listen to the presentation. Thank you, and have a blessed day further.
Thank you also, Dr. Peter. It was a great pleasure presenting and sharing this information with this audience here. Thank you all for for listening and your interest in this.
Thank you. Bye-bye.
Bye.